Okay, we're going to finish up. I think this might be the last talk, but basically it's going to be a lot of redundancy with what we've already talked about today, because it's going to be mostly technique about how to achieve fixation in odontoid fractures, as opposed to whether to do them or not. We all understand and we all know that the healing rate of odontoid fractures, particularly in the elderly, is not great unless you achieve some sort of fixation. And like everything in the spine, there's always, debate over what the best way to achieve fixation is. And in the, cervical spine, there's two ways to do things, from the front or from the back. And so that's what we're going to be talking about, the juxtaposition between posterior fixation at C1, C2, or direct fixation of the odontoid with an odontoid screw. There's some potential benefits of direct anterior fixation that we haven't talked about yet, and that's preservation of C1-2 joint motion. Now, a lot of these older people that have odontoid fractures, that's not as big a deal. But if you have a younger patient who comes in with an odontoid fracture and you're doing a C1, C2 fusion on them posteriorly, they're going to lose a lot of that rotation. And some of they can get it back, but they're not going to get it all back. So as a result, an odontoid screw has certain benefits or particular interest from that standpoint. Shorter surgical times, we're all pretty quick at actually doing both of these procedures now. So I think, that was sort of a moot point. There's certainly a lower risk of vertebral artery injury because you're not anywhere near it. And if you are near it, then you're in deep trouble. And you can also avoid the prone position. So it's a lot easier to position somebody for an odontoid screw. And, you don't have to turn them over and do all that kind of stuff. So it can be very, very beneficial from that standpoint. Now, direct fixation of the odontoid with a screw has been around for a long period of time. The oldest cases in the literature are almost 40 years old now, and they showed very high fusion rates with one screw. And so there are a lot of subsequent articles that have shown that one screw fixation is identical to two screw fixations in most series. I'm going to describe a slightly different series that we published from Utah in elderly patients, but usually one screw is just as good as two. Now, as we've already talked about, having two C-arms is absolutely key. And I think that's key because I tried to do one of these once with just one C-arm, and it was the biggest headache. I'll never forget it. And so as a result, I would never do one of these without two C-arms. And you can position them here. Now, one thing you got to do is you got to get a bite block in there. And the thing I use for a bite block is actually a wine cork. And so this is something that Ron Affelbaum taught me. It's always good to get, the jaw opened as much as possible. You notch a wine cork and you get a great view of the odontoid in that AP view if you go ahead and do that. So that's what you can see here. Now, Bijan makes his incision a little higher. I make my incision a little lower, not quite this low, not down at C6-7, but I tend to make an incision, about C4-5. Now, the other thing Bijan was mentioning is that you can't do this on somebody who's barrel chested because you can't get the actual angle. And that's the whole idea, is what you want to do before you actually do one of these, before you even make the incision, you should take a K-wire and superimpose it on the odontoid where the trajectory of your screw would be. And if you think you can do that without bumping into the chest, then go ahead and do the case. But if you've got somebody that's so barrel chested, you can't possibly lower your hand enough, it's always good to have sort of the backup of a C1-2 posterior fixation if that's in fact the case. Here's what we do. I put patients in halter traction. I use my incision down around C4-5. This is one of Ron's patients. He liked his incisions a little lower, but he did have to look up, as Bijan had mentioned, very high. And it's difficult to see up to that C2-3 disc space the lower you put your incision. Now, one thing you got to do is you can't put the screw or start the screw too much on the anterior body of C2. You have to get into the C2-3 disc space. Now, the system that I use is a non-cannulated system. So it's just you go ahead and drill and put the screw in. This is how you get it started, though, is a thick K-wire to go ahead and make that starting point for the drill. It's almost like, having your drill guide kind of go in over that K-wire, as you can see here, so that you can go ahead and get your trajectory right. There you can see the drill guide inserted over the K-wire. That's actually in the 2-3 disc space, which is good, what you want to do. Any more anteriorly would be far too anterior, I think, in this situation and would lead to a problem. Now, I'll go ahead and drill all the way to the apex because I'm not using, again, a cannulated system. I know there's cases around here where people have put K-wires pretty close to the brainstem. And as a result, I do not like a cannulated system. So I will drill all the way to the apex of the odontoid, as you can see on that lateral view right there, and go ahead and make sure that I know what my length is based on that drill. Now, what we'll go ahead and do then is tap over that. And you tap all the way to the distal cortex. And the reason you tap all the way to the distal cortex is because you want to use a partially threaded or lag screw. The whole idea behind the lag screw is you go ahead and capture that distal cortex and then bring that fragment back so that you have good apposition of the fracture fragments, and that fracture is actually seated to the rest of the C2 vertebral body. So this is what you want to achieve with that lag screw when you go ahead and use a screw. Now, the first screw is always a lag screw. The second screw, you can go ahead and use a fully threaded screw. I usually just use one screw. I had the benefit of spending quite a bit of time with Ron Affelbaum, who is an absolute master at this. I mean, he could fix an odontoid from an anterior approach like nobody else. But oftentimes it's so cumbersome to get two screws in that one screw would suffice, and go ahead and use a lag screw if that's what you're going to do. Now, if you look at Ron's series, he published a series that's 20 years old now of 147 patients, and found that his bony fusion rate was 88% in recent fractures. Now, interestingly, he tried this a couple of times, or about 12.5 times, in patients who had fractures over 18 months. It doesn't work in chronic fractures. It doesn't work in chronic non-unions. He had these fancy curettes you could put up there and do all kinds of things to try to denude the bone and so forth. Don't use an odontoid screw if somebody's got a fracture that's more than, I think, a month or two old, to be honest with you. One thing he did find in his series is that he found that fracture orientation was a significant predictor of failure to fuse. And in this, what you can see here on the left, these anterior oblique fractures, where the fracture comes from the posterior cortex and kind of goes down into more inferior pattern in the anterior cortex, they had a much higher non-union rate, the anterior oblique fractures, than did a transverse fracture or a posterior oblique fracture. Is interesting in his series, not number of screws, not degree of displacement, not sex, not age, were predictors of fracture failure, but it was that orientation that was the most significant predictor of failure. Now, we went back and looked at just the series of patients who were over 70. And we had 57 of them in this series. And we used either one or two screws, and we categorized them as stable, either with a bony union or a fibrous union, or unstable, where you had obvious movement on flexion and extension. And what we found overall is that the overall stability rate was actually much greater in these older patients when you use two screws. Now, this is the only series that I know of in the literature that actually shows that. And it's only in these elderly patients. But as Dr. Robbie had mentioned, what the problem is trying to get two screws of lousy bone is not very easy to do. And so as a result, I tend to use one screw, but Ron could go ahead and do these things like nobody else. And you'll see here, what he did was he overlapped the screws and actually put one more posterior and one more anterior, and could achieve fixation that way. And I think that's why we got such good results from these odontoid screws in these older patients. Now, the problem is the complications associated with this. And here's the real problem. These patients had a lot of dysphagia. This is a retrospective series, so there's some selection bias. You don't really get all the details. We've still found a third had significant dysphagia, and over 20% needed a feeding tube for a significant period of time, not just mild dysphagia we're talking about. So the complication of dysphagia is something that has precluded me from using it in the older patients as much as I used to. So that brings us to posterior C12 fusion, which is, a lot of these patients are older patients. So what do we do? Well, the initial description was the C12 transarticular screw. We've talked about that a little bit today. What you want to do is, again, make sure you have a pathway for this. And you can see here where you're going with these transarticular screws. You want to go through the isthmus of the pars in C2, go ahead across the C12 joint, and then go ahead and grab that lateral mass of C1. And this is what you're trying to obtain. When you're using transarticular screws, and I think any C12 fixation, I always obtain a preoperative CT to assess the position of the vertebral artery. Now, this was mentioned before. You want to use a military tuck, but you have significant problems sometimes doing this. And this is why C12 modular fixation is better nowadays, because if you have thoracic hyperkyphosis or cervical hyperlordosis, you go ahead and you have a very difficult time getting C12 screws in. This is the starting point that you can see for it. I go about, you want to palpate the medial portion of the pars of C2, visualize the C2 pars on fluoro. Your starting point is on the medial C23 facet joint. It's about, you go about 3 millimeters up from the C23 facet joint and 3 millimeters lateral from the medial portion of the facet joint. You want to aim up and slightly in and check your trajectory before you open up. One thing we used to do is do a separate stab incision so you could go ahead and get the trajectory. So you prep all the way down to T1 when you're going ahead and doing these. The problem is not everybody has anatomic suitability for a transarticular screw, and 20% of patients will have an anomalous or high-riding foramen transversarum. And this was published in one of Reg Hayes' former fellows, Chris Paramore, that showed 20% of patients will have a vert that precludes placement of a transarticular screw. You can use one screw. It's significantly stiffer than just wires alone, but not quite as stiff as two screws, but close. So this is even acceptable in somebody who had an anomalous vert on one side. The problem is you can't do it if somebody doesn't have a reduced spine. So you got to do whatever you can to get this spine reduced. This is actually an interesting case of somebody with a chronic transverse atlantal ligament injury who had chronic C12 subluxation that was irreducible. And what we did was we went in and did a transoral, just went ahead and took all that pannus out from behind the C1 anterior arch. The spine fell back into position, and then you could use transarticular screws. You couldn't have done that if you hadn't gotten them reduced. So, it's something that with the modular C1 lateral mass screws and C2 pedicle screws that you can go ahead and do. The thing you need to know about the posterior situation is the complications here. And it's, vertebral artery injury and stroke are the things that you worry about. Neil Wright and Carl Laurissen wrote up, it was actually a survey. And in the early experience with transarticular screws, they found a 4.1% incidence of vertebral artery injury per patient. The stroke rate was 0.2% per patient. Now, this was a survey, so you got to take it with a grain of salt. But people will say there's a 1 to 2% incidence of vertebral artery injury when you're doing transarticular screws. And I think that's something you also have to think about when you're doing C1 lateral mass screws or C2 pedicle screws, okay? You got to think about the incidence of vertebral artery injury. You worry about non-unions, suboccipital neuralgia, the usual things you worry about. And, vertebral artery injury is really the thing that's most prominent. Now, let's finish up here with just the most current techniques, which are C1 lateral mass and C2 pedicle techniques. Some people will call it a Harms construct, but Atul Goel actually described it before Dr. Harms, Professor Harms. So, you better be careful, depending on what audience you're talking to, what you call this thing. And so, where you want to go ahead and start is what we showed before. Now, this is important because where you want to see is the C1 lateral mass right there. That's your entry point. So it's right where the pedicle comes down in C1 at the junction of the lateral mass is where you start your C1 lateral mass screw. So the junction of the arch and the lateral mass. The C2 pedicle, as Rick had mentioned earlier, is in the upper inner quadrant of the pars, okay, as you look posteriorly, as your pedicle's going in this trajectory, okay? So those are the starting points for each of those screws. Again, the C1 lateral mass screw you can see here. What you want to do is emulate the blue arrow, not the yellow arrow, which is headed towards the vertebral artery, or actually the red arrow, which isn't going to cause a spinal cord injury, but isn't going to give you a very good bite. And I've seen screws placed there, and they frankly don't work. So as a result, you want to go straight up and down is what I do when I go into my lateral mass. Now, what I do is I use lateral fluoro. I don't use navigation so much for C1, C2 fixation. And you can see where you aim here is sort of the center of the anterior arch of C1, and that will give you the appropriate trajectory. So you're aiming up, and you're slightly or straight or slightly convergent in the axial plane. And so those are your trajectories when you're looking at fluoro and just trying to do this with non-navigation. And here's where your screws go. You can see them coming down right there, and that's kind of the trajectory that you want to see. What I usually do is I'll drill to 18 or 20 millimeters. I use a smooth shank screw, and my typical length is anywhere from a 28 to a 32 screw. And that's my typical length for a C1 lateral mass screw. You can see the trajectory here again on this cadaver. And what I'll do is, again, I will not take the C2 nerve. I'll go ahead and push it inferiorly. And I still will go bicortical, but frankly, you don't have to do that because the pullout strength is pretty good from a unicortical screw. So unless you're trying to get a lot of reduction, take what I say with a grain of salt and probably just go unicortical. Now, you can do some nice things. This is somebody with an unstable C1 fracture. And you can see here where if you put in C1 lateral mass screws, you can pull those fragments back together and then go ahead and fuse the patient to C2 and go ahead and achieve a good reduction. And I think, this is something Jens taught me at Harborview. You really get independent fixation of the lateral masses and you can pull them together. Now, there's a bunch of possible sites for C2 screws. We've gone over this a lot already, so we won't belabor this as much. You've got your pedicle screw here as seen in orange. You've got your pars screw as seen in yellow. And you've got your interlaminar or translaminar screw, which we've talked about significantly already. What you'll see is a C1 lateral mass screw and a C2 a pedicle screw or C2 a pars screw has less stiffness than transarticular screws or a C1 lateral mass and C2 pedicle screw. So again, that harkens back to what Rick's been saying all day, which is the pars screw is just not as good as a pedicle screw or a translaminar screw. Now, what you can see here is where you start them. That top K-wire up here that you can see right here along this arrow is where you start a pedicle screw. This is where you start a pars screw right down here, okay, that inferior K-wire, and that's the trajectory right there. For a C2 pedicle screw, you go about 30 degrees medial and about 30 degrees up. I aim for the base of the odontoid, as you can see right here on that lateral image, and that usually will give you a pretty good shot at the C2 pedicle. Now, you got to be careful because, the C2 pedicle is pretty narrow. And here's the example of what you want to hit as you go down that pedicle and into the arch and into the vertebral body. And so this is the trajectory you want to see along that C2 pedicle. And this is what you want to see in a sagittal view right there. You can actually get in a pretty good screw. And these are usually anywhere from 22 to 24, even 26 millimeters in length. The problem is you also got to know where the vertebral artery is when you're placing a C2 pedicle screw. So I, again, recommend a CT scan if you're going to go ahead and place any instrumentation in C1 and C2. What you see for a pars screw is here. That's more of a 14 to 18 millimeter screw, and it's a similar entry point to the transarticular screw. Now, oftentimes with a pars versus a pedicle, there's a trade-off of safety versus rigidity. But as Rick had mentioned, you can still injure a vertebral artery even with a pars screw if you're not careful, and I've seen it done. So be very careful and know where the vertebral artery is so you can avoid it. Now, the nice thing about these modular constructs as opposed to transarticular screw is you can get reduction. And here's somebody who sort of had a chronic fracture of C2, and you can see here what we were able to achieve and reduce it by putting in lateral mass screws and C2 pedicle screws. We've talked about translaminar screws. We're not going to go over those anymore. But here's one slide showing that actually the pullout strength of a pedicle screw is greater than the pullout strength of a laminar screw is greater than the pullout strength of a pars screw. So again, the translaminar screws are a good alternative to pedicle screws if the vertebral artery is in an anomalous position. And so, for odontoid fractures, you have a variety of options. You can use, lateral mass and pedicle screws. You use lateral mass and pars screws. You can use a combination of them. And so you have a lot of different things in your armamentarium. So when we start talking about odontoid fractures, we have to talk about posterior fixation because of all the complications in the elderly patients that you can get from an anterior approach. Well, what's the efficacy of it? There are a bunch of series that have now been published in the literature. It's not having a good direct comparison of anterior for posterior, but they show high fusion rates in posterior fixation patients compared to much lower fusion rates with anterior screw fixation. And in trauma patients, this is 27 patients, 83 years old, who had posterior spinal fusion with transarticular screws. Even though there was a mortality from this, and there's a mortality even if you don't operate on odontoid fractures in the elderly, their healing rate was quite good, 95% in these elderly patients. This is a recent paper from Clark, and they showed that there was a lower 30-day mortality, but still a significant one-year mortality in patients who had odontoid fractures that they did C12 posterior fusions on. The thing to remember, though, is you still can have dysphagia even when you go posteriorly. And it's something endemic to this patient population. The problem with dysphagia, there's a 14.5 times greater risk of mortality when somebody has swallowing difficulty afterwards. Can't preclude you from doing it, but you just got to talk to the family and say, look, patients, even with a fixation posteriorly, can still pass away with odontoid fractures. There's a high mortality rate whether you operate or you don't. And Jens has showed that very nicely from the AO literature. So that's a brief overview of the different fixation techniques for odontoid fractures. Thanks for your attention.
Super. Can you stay there? Rick Sasso, you're still online, right? I just saw you.
I'm here. Can you hear me, Jens? Yes.
Can you get back to the Odontoid? So let's start with the Odontoid. So between you and Andrew, I think you've covered about 50% of the world literature, and that might be an underestimation. So let's start with the basics. We saw Bijan's very careful cannulated screw system. One more time, I'd love to hear your thoughts. 1 screw versus 2 screws. I know what you're going to say, but just tell the audience why 1 screw suffices. And how perfect do you have to be? Does it have to be coaxial to the axis of the atlas? And tell us a little about what happens if you don't get a true compression screw effect.
All right, so 1 screw is enough. 1 well-centered, right in the middle screw, but you have to lag it. And you lag it either by design, by technique, or with a partially threaded screw. Personally, I like to do it with technique where you over drill the body fragment, tap the odontoid fragment, and then the screw goes through the gliding hole, grabs a hold of the odontoid fragment and pulls it to the body fragment. Biomechanically, you have to have that lag fixation, that compression, in order to have the highest stability across the fracture for it to heal. I agree with Andrew. I don't use a cannulated system. I will tell you that Ron Affelbaum was the initial, I mean, he had a great cannulated system. He does not use cannulated systems anymore now because of the potential for binding, shearing, or driving the K-wire. And he's seen way too many complications with K-wires being driven into the brainstem. So he has stopped using cannulated systems. Plus the screw is weaker because it's got a hole in the middle of the screw. So, and it's a lot easier to place a 2.5 millimeter drill bit perfectly across the odontoid fracture as opposed to using a K-wire. K-wires are hard to control, very, very difficult. And Magrel taught me that 30 years ago while watching him put odontoid screws across. And so those are my thoughts, Jan. That was great.
Two technical questions, and then Amir has a question. So how do you prevent spin-off? So I had a couple of these really transverse fractures with no fracture interdigitation. How do you prevent an osteodense young male who was a knucklehead? How do you prevent that from spinning off as you're engaging that odontoid tip?
Okay, so it's a fallacy unless you have OC disassociation. The alar ligaments are so strong they actually hold the odontoid so it doesn't spin around like a top. Now, if those alar ligaments are gone, they'll spin around like a top, but then you have more of a problem. You need to do an OC fusion as opposed to just fixing the odontoid.
And one more question, then Amir's turn. What is the most common failure mechanism of odontoid screw fixations?
Well, I will tell you the most common failure is that you start the screw too anterior. Andrew did a great job showing the importance of putting it into the disc space and starting in that strong bone. If you start it too anterior, which is the most common problem, you get a shallow shot across the fracture and you're in really, really weak bone. And so that screw tends to just pull out. I do agree, though, that I don't use this technique as much anymore in the older population, because even with a perfectly placed screw, the osteoporotic patient, it just is not that successful. So I will do a posterior C1, C2 fixation as Andrew Dailey showed.
Thank you. Yeah, I think maybe the one thing that we didn't talk about in this very exhaustive review is, Jens, I know you like the kind of posterior arch lateral mass type approach. I don't know if anybody else has any commentary. I find that if the kind of posterior arch is more robust, you can get a really nice trajectory through that and directly into the lateral mass. Whereas if it's kind of flimsy, I do worry about protecting the vert above it. Is that kind of a variation you use, or do most people feel like they want one technique or the other?
I think I know what you're talking about. You mean starting the screw in C1 higher in that lateral mass. I'm so worried about the vert that I tend to put mine directly into the lateral mass itself. I want to see the lateral mass. I want to see where that pedicle
Start
comes
right on the
down.
mass.
That's just me.
We got a title page out of Journal of Neurosurgery spine there that time. We put a Penfield 4 onto it. We have a nice cartoon of that, and then drill down the arch to get onto the lateral mass. So the whole goal is to stay between scilla and charybdis, the rock and the hard place, or in this case, two soft places, the C2 root. But so we basically put onto the sulcus a Penfield 4, protecting the vertebral artery, and then having a Penfield 1 or so on the C2 root. And we dissect that exactly what you did in your beautiful dissection. So we see the lateral mass of C1, and then just with a Midas drill that down so we have a firm starting spot. Rick, your thoughts, arch screws versus kind of tenting the C2 root a little bit?
Yeah, so I'm a strong believer. I agree with Andrew. I started in the lateral mass. I put a Penfield into the C1, C2 joint and pull the C2 nerve down. This is all about mobilizing the C2 nerve root. If you can't mobilize the C2 nerve root, it does bleed like crazy, and that's why people have struggled doing that. Jens, I completely agree that if you start the screw in the posterior arch of C1, you have to do what you do, Jens, which is mobilize or protect the vertebral artery. And the Japanese do this as well. They describe it very, very well. I think what is a mistake is to start the screw in the posterior arch and not protect the vertebral artery. That's where you get into trouble. Personally, I would much rather deal with the C2 nerve root and the venous complex around it than dissecting above and putting a Penfield underneath the vertebral artery.
Jean?
Bijan has a question. Do you have a microphone? Yeah, great.
Sometimes what you said is absolutely true. I think there may be a millimeter to a millimeter and a half hangover the C1 arch. So I use a 5-diamond drill. First of all, I use a Penfield 4 to touch the lateral and medial aspect of the lateral mass. And then I use a 4-diamond or 5-diamond to produce a groove in the inferior aspect of the C1 so that the screw would go right into the C1.
So final scenario here, and then I think we have the final lab, and that is Andrew showed how you can distract C1 and C2, and that's a really cool thing. So let's look at the scenario of a C1 laminectomy being necessary where the C1 arch is broken off. And you need to do an arthrodesis C1, C2. What about facet arthrodesis? Let's start with you, Rick. Do you do anything for a facet arthrodesis, or is instrumentation enough to get it to heal?
As I said earlier, I do decorticate the joint since you've already exposed it, and put graft into the joint.
So just loose graft? Okay.
There are actually some folks have allograft spacers that are available that look sort of like, squares or rectangles that you can go ahead and place in there. I've done those about a half a dozen times in people who I've wanted to reduce a basilar invagination, or as you say, who there's the C1 arch is incompetent and there's no place to put a graft. Who knows? It's anecdote, but it seems to work.
Yeah, no, I've done occasions. I split an allograft in two and make a small little arch thing out of that. I don't like drilling into the C1, C2 joint because a lateral skip would hit the vertebral artery. That would not be favorable.
Yeah, in classic Jens fashion, I think I did a C1, C2 with him where he put a ACDF cage in the joint space.
Yeah. So any other final concluding comments? Rick, maybe a big picture perspective. Odontoid screws. The ultimate MIS surgery, or has the time come and is kind of going away?
I think it's going away, Jens, which is unfortunate because I think it's one of the most elegant operations that we've done as spine surgeons.
I couldn't agree more. It's been so cool to have it, and it's just kind of clinically not applicable anymore. I mean, I don't remember an odontoid fracture now that's under 80 or so. I mean, we're just about happy to have a 70. Right. And I'm very disappointed. Exactly. Bijan wouldn't do an odontoid fracture in a 60-year-old, anybody older 60. I don't qualify anymore for you, Bijan. I was very, very disappointed in that.
There are exceptions.
So now we'll switch to the lab. Main room to, thank you, Andrew. Very good.